now implementing that referral process. Another capacity is to address gaps in needs in services, to increase connections to other veterans, to address stigma. Historically in the veteran community, if you are suffering with a mental health or even a substance abuse crises or something that's kind of just been nagging at you, a lot of veterans will keep that to themselves. A lot of that is from what many veterans are told while they're in the military. So to keep these things to themselves, some of them they would think being put out of the military or risk a security clearance, things like that. So in light of that, with the veteran community, the main thing I see is to get ahead of some of these things and put resources out to them that they can ascertain, that they can get themselves. Part of that, once again, networking with the VA and getting ahead of some mental health crises that veterans may face, we put together, myself in partnership with the VA and Oakland County Public Health, put together a suicide prevention and military sexual trauma workshop May 22nd at 10 a.m. and it'll be in Pontiac. Once again, of course, because suicide is something that we wanted to eradicate altogether, and also because during the holidays, your Memorial Days to your 4th of July, there may be an uptick in veteran suicide or substance abuse and things like that because of the memories and things like that. So to get ahead of that, we put this workshop on, and hopefully we can help veterans and their families overcome these things. Many veterans feel embarrassed over having mental health substance abuse needs, and also the issue of MST, military sexual trauma. That's part of this workshop as well, to address that, because that can be something that's very traumatic and almost embarrassing for individuals to have to face that. Since veterans in the Metro Detroit area are predominantly male, 90% compared with fewer than half of non-veterans. Half of the veteran population is 65 years or older, compared with less than 20% of non-veterans 18 or older, and veterans are more likely to have a disability, 29% compared with 17%. Estimated 31% of troops returning from Iraq, Afghanistan have a mental health condition or reported experiencing a TBI. Also, in the arena when you talk about PTSD and you talk about some of those traumas, not every veteran that experiences experienced PTSD or trauma was in combat. I've had veterans experience these things in boot camp, right there in basic, being stationed over in Germany, just different things like that. That PTSD, that trauma, can hit at any point in a veteran's life from boot before he even gets deployed out. Okay, so many veterans do not qualify for Medicaid and are not registered with the VA. So in light of that, not every veteran qualifies for VA medical services. So a couple of things with that. If a person does not have an honorable or an other than honorable, or even a general, he or she may not qualify for VA services. Michigan being a National Guard Reserve state, you're not considered a veteran unless you've done 20 years in the Guard or Reserve. So then at the age of, my understanding is 60, they can start to reap some kind of retirement benefits. So if I was in the Guard Reserve and I never was deployed, never was called up by the President of the United States, I don't get, benefits. So that's where I may fall into that area, maybe not receiving mental health services, rather. So with that as well, trying to bridge that gap as well to help our veterans that are suffering from the mental health conditions to get that particular help. So once again, that's in the processes as well, trying to help that capacity. Increase connections to other organizations serving veterans. Veterans that do qualify for VA services, assisting with helping helping to navigate that. You just tell a veteran, hey, just go down to the John Dingle, you'll be okay. I'm sure, you know, some of us have been down to John Dingle. I've been on there various times, and it's overwhelming each time I go there. It's a gigantic hospital, literally, and that could be a lot of stimulus for a person that's never, you know, entered into that that system. So that's where I've been trying to reach out to the VA and kind of help bridge those gaps, maybe give the guys and got somewhere they can, a point of contact, you know, that warmer handoff. We're always doing some research to try to research some funding for initiatives for veterans. So the government is constantly releasing, you know, different grant opportunities, things like that, to help veterans and their families. One thing I think kind of gets left to the side, for instance, my father's a Marine, and I have uncles that served in Vietnam and Army. My family was impacted by what my father experienced in the Marine Corps. He can sit me down today, no matter if it was 50 years ago, and tell me, son, exactly, you know, what he marched through. And he had to parent me from that view of being a Marine and just that kind of deal. So with that additional funding to assist the family, especially the spousal support, the children that need to, you know, dad or mom is now just coming back after being 6 to 8 months being gone. So always looking at funding from that aspect as well. So there are measurements, outcomes, and evaluation are to be developed as the strategic plan is finalized. So once again, this initiative is from the state, and so they're trying to capture, you know, how many veterans in Oakland County are receiving these services. Of course, Macomb County, Washtenaw County, things like that, but my focus is Oakland County. So they are looking to see how many veterans in Oakland County, what are these gaps in services, what do they need, what is the help that can be additionally provided. And once again, with the, and that's why we're hired within the CMH to address, once again, that gap in substance abuse and mental health. Okay. Investing in and supporting peer-to-peer groups. Another one of the bridging of the gaps in the veteran community is to help set up more peer-to-peer groups. We know there are a lot of peer groups at the VA, but once again, if I'm a veteran, I live in Clarkston, may be a little challenge for me to drive down to the John Dingle. So perhaps exploring more peer groups out in the community. There was a gentleman that he's a veteran at the Rise Center, and him and I discussed possibly a peer group. A lot of veterans don't like to disclose to civilians what they've gone through. They feel we can't understand. And so to have other veterans in the arena will help get these needs met, and at the same time, coupled with you know, the mental health therapy, now that person's on that road to healing. He has the peer support, and he has the intensive therapy as well. So that model has shown to be successful. And also including the wraparound services. Wraparound services, my thing is not just giving that veteran or family member a 1-800 number. I think that's very indifferent, that's very cold. So one of my points is to give them live contacts, live points of reference, and following up, excuse me, with that veteran and or family member within a week or so. How'd it go? What's going on? Did that work? If not, let's move you on to another resource or referral. So that's very, very important in wraparound services and more of the personal to me. Policy implications. So their policies, procedures, and protocols are to be developed with this is a finalized strategic plan. So we've been working on a strategic plan, and I have my own strategic plan that I've kind of put together once again to help address veterans and their family members. Providers in public mental health system having a universal system in the coordination of veterans and military families. So once again, we're in the process now of developing like a universal referral form that Easter SEALs utilize, TTI, whomever touches the veteran or family member in Oakland County, having that universal form being implemented, at least that data being implemented or captured, so I can follow up, or we can just make sure their needs are being met. Once again, not following the path of when the Vietnam veterans came home. No thank you for your service, just kind of go to work kind of deal. And many guys got kind of left. So eliminating any of that and make sure we're gathering, if you're reserve, guard, active duty, anything, we're following up, we're touching base with you, either myself or whomever else. Okay. So my services are funded by the Michigan Department of Health and Human Services. 50% of the funding is mental health block grant. The other 50% funding by substance abuse block grant as well. And we're always researching other grant opportunities as well. So that is it for me. I will stop. I think I've...
Are there any questions at all for Mr. McDonald? Dr. Klotz.
Chuck, hi. I've always wondered, being that, I mean, you come from a military family and certainly, you know, proud that your dad was a Marine, et cetera, and you went through a lot as a family. But the fact that you didn't, that you were not in the service, what kind of hurdles, if any, are you dealing with the men and women that you're dealing with? I mean, is that held against you? Is there a barrier? What?
That's an awesome question, sir, because initially when I first started out, folks would say, you know, are you a veteran? Now, I was in law enforcement for a moment, and so that police training, that paramilitary, it's kind of, you know, we had the sergeants, lieutenants, captains, things like that. But at the same time, too, so outside of law enforcement, I've been working in the veteran community since, pretty heavily since about 2008, and a lot of it is gaining their trust. They want to see the sincerity, the trust, and things like that. So initially there were some hurdles, you know, who are you? You didn't serve, where is all this coming from kind of deal. But it was building that trust, and I found that showing them basic, you know, like human compassion and care, and the fact that, you know, wanting to help them has knocked down a lot of those barriers that way. And like I said, coming from law enforcement, that helped with understanding some of the different nuances and things like that.
I would say your personality really transcends, you know, some of the issues we're talking about. I mean, whatever, you know, you don't have in, say, the particular experience they might be asking about, but your personality is such that you really pull people in, so.
I appreciate it, sir. Thank you for saying that.
It's true.
Any more questions for Mr. McDonald? Yes, go ahead, Kelly.
Did you bring a copy of your presentation, or do you have some literature on your foundation?
I have my PowerPoint that I printed up here. I do have the flyer for our suicide prevention and military sexual trauma workshop. I'm make sure all you guys get that. And I do have my brochure for my position, so I do have that as well.
We can certainly get you the presentation as well.
Now, this is a new, any other questions? I'm sorry. Okay, this is a new job then. I don't recall it ever being part of state government.
No, no. This is a new position, a new role that, well, I guess new to me. I guess it's been around for a couple of years, from my understanding. But well, the concept has been around. But yeah, it's new.
Okay, well, welcome.
Thank you.
Okay, next on our agenda is response to the opiate crisis, and I'm going to turn to Christina for that.
Okay, good afternoon, everyone. It is not always fun to present on these issues, especially with what's going on with the opioid crisis. I think that most people are aware of fentanyl and carfentanil, which are very strong opioids that are being cut with heroin and also used just alone. Carfentanil, for example, is 800 times more potent than heroin. And so even the tiniest granule of it getting on your skin can cause an individual to go into an overdose. And the entire nation is being plagued with not only the prescription opiate crisis, the heroin crisis, but fentanyl and carfentanil have unfortunately caused us to not yet reach the tipping point in terms of overdose deaths. And so we really are very data-driven here, and so we're monitoring data all of the time. And I've started to look at the preliminary statistics for 2017, and unfortunately, we, similar to the rest of the nation, have not decreased in our opiate overdose deaths in Oakland County. Roughly, the preliminary reports is that we've about doubled from 2016, which is saddens me greatly, it concerns me greatly, despite the fact that we've added numerous amounts of prevention and treatment programming to make our communities aware of what is happening and also bring resources to them. I also know at the federal level and at the local level, law enforcement is working round the clock to address the issue of these illegal substances getting into our country and also being sold throughout our county and all of the counties across the nation. So I wanted to just give a recap to the board and talk to you just a little bit about what we're doing and continuing to do to combat the crisis. I think most are aware, and I won't speak about it much because it is being discussed a little bit later in the presentation, but we did open the Sober Support Unit. What I absolutely am happy about with the Sober Support Unit is it provides 24/7, 365 days a year access to treatment. So if it's 3 o'clock in the morning and someone says, I can't do this anymore, I really need help, they don't have to wait to be connected to resources. They can go to the Resource and Crisis Center. Common Ground is our provider that is delivering the service, and they can literally walk in, they will be serviced, and within 24 hours will be placed in treatment that is appropriate to their substance use disorder. Now again, this is obviously for people with opiate use disorders. However, anyone with a substance use disorder, whether it's cocaine, it's alcohol, etc., no one is being turned away in terms of the type of substance that they use. So that is available, and again, we have been able to transfer individuals to care generally within 23 hours. One of the other things that we're looking at doing is originally when we were equipping our law enforcement community with naloxone, law enforcement officers in the beginning really asked to be equipped with the 2 milligram dose. Because a person, when you save them from an overdose, they go into immediate withdrawal. So sometimes a person can, be a little bit combative because they're feeling very sick. They just came to very immediately. And so there was some concern from the law enforcement community about how combative people would be. What's unfortunate to say, but fortunate at the same time, is that our law enforcement community officers around Oakland County have very much embraced utilizing naloxone to save lives. I've often heard a very different mindset, which is makes me very happy. I was at a town hall meeting that I participated in Southfield recently, and both the fire chief and the police chief and our sheriff at different times got up and said, the fire chief first said was, we have to change the way that we assist someone in an overdose. People were afraid that they would be in trouble. They were afraid that we would judge them. We need to only meet them with compassion, caring, and help them be connected to services. The police chief said the very same thing, and then the sheriff came up and his first words were, we cannot arrest away this disease. We need to connect people to treatment. So we've seen a major shift in attitude and focus, but also we are responding to the requests for law enforcement community. And because of carfentanil and fentanyl, they've asked for the higher doses of naloxone, or actually Narcan. which is the brand name. So because it's taking them 2 and 3 doses to bring a person out of an overdose. And so we know that that's fentanyl and carfentanil causing that, and so we want to equip our officers with what they need so they can help save individuals. All of our EMS and the ambulances are already equipped with higher doses of Narcan, but we did the research, and I've talked about this before, that 88% of the time law enforcement is first on the scene. So we just want to make sure everyone has the ability. We have to date saved well over 300 lives with our law enforcement initiative. So we know it's helping, and we are going to continue that for sure. The other thing that we've put a large focus on is increasing access to residential treatment. I've talked about this in the past, that the state rules mandate that we place people within 14 days, and we've never really adhered to that because we just felt it was a bit too long. And I've talked also before that we are able to get people in between 48 and 72 hours. Well, through the sober support unit, we've been able to get them in treatment within 24 hours. We want to make sure anyone who comes in for a screening has the option to go immediately or within 24 hours. So we are working very closely with providers and those providers that are interested in increasing the ability to offer more beds for residential treatment and withdrawal management, or what was once known as detox services. I'll talk a little bit about that more in just a moment. We are doing huge media campaigns again, bus ads, billboards, Imagine theater ads, so when our youth or anyone is watching a movie, you can see that. And we've added radio ads for our awareness campaign because we know we have to continue to get the message out there. We did start our jail medication-assisted treatment program because we know one of the highest rates of overdose are being released from jail, and we want to begin treatment when a person is incarcerated, and we have a recovery coach that follows them to their first appointment, so we hope that there will be follow-through. We did research in the past, and so did the National Association of Drug Court Professionals, and the statistic was as large as 95% of people were not following through with treatment when released from jail, and so we knew we needed to start a program within our jail. We have an initiative where we can provide transportation to treatment when it's a barrier, especially for individuals with opiate use disorders under our state targeted response grant. We are working with the Michigan Department of Corrections, so with 2 different programs, and that is the prison system as well. We have a Withdrawal pilot, which is a medication that is used for opiate use disorders and actually alcohol use disorders as well. And we engaged in that pilot as well. And we also, through our state targeted response grant, have what's called the Mission Criminal Justice Program, which is a very robust program for individuals that are in prison and once they leave prison. We've also, through state targeted response, initiated the Strengthening Families Prevention Program through our providers. That is it's the Iowa model, which is a specific model. It's an evidence-based program, and it's a program for families and children, and it's specific to the opiate crisis as well. We increased our medication-assisted treatment providers, so there is more access to treatment. We are working on Project Assert, which is putting our recovery coaches in emergency departments. So for example, when an individual has experienced an overdose and has been medically cleared, the recovery coach can work with the individual and hopefully motivate them to go straight to our sober support unit and then enter into treatment. And we're launching another RFP to increase our recovery housing efforts. Our recovery coaches gave us feedback and mentioned that that's one of the largest things that are needed is more safe and sober housing for individuals as they continue to get well. The last thing, I want to talk a little bit about the Public Act 2 funds, because those are a flexible fund source that are greatly appreciated because it allows us to do these additional community benefits often that neither Medicaid nor the block grant fund, and that are unique to our to our county, and that really truly help the entire county as a public benefit. And so Oakland is one of the few PHPs where take someone in and immediately provide transportation to treatment on a 24/7 basis, and that's in large part due to the PA2 funds. So the Sober Support Unit is completely funded with Public Act 2 funds. And so we wouldn't have that and that ability for individuals in the county of Oakland if it wasn't supported by that. And so I want to thank this group and for supporting us in those efforts. A large part of what PA2 is assisting with is increasing residential presence. Our providers are nonprofit, and to really do some expansion to better serve the people of Oakland County, that they need that support. And so we're working very closely with providers as well. And Meridian Health Services, for example, is very close to opening a new unit. Well, they will have 85 additional beds. That is going to get us much closer to literally someone coming in, being screened for services and being able to leave and be directly connected right away. Because that is our goal for every person, that we can give them services immediately, and it's ultimately up to them if they need to wait a day or two. So with that, does anyone have any questions for me regarding, yes, Dr.
Can a person refuse treatment out in the field? I mean, if they're, let's say they're oppositional defiant and just they don't want help, or they don't want the Narcan or whatever. If they say, I don't want this, what do they do? Do they, first responders, do they administer it or not, or?
So there was a law passed a couple of years ago in which first responders will never be held liable if they save someone in an overdose. And so obviously someone's completely unconscious when they're overdosing, but of course they reserve the right not to continue with treatment. The thing about an overdose and reversing it is that you have about 30 to 90 minutes before a person's going to go back in the overdose. So it's considered an emergent situation, and generally a person is put in an ambulance and taken to the emergency room. They have to have further medical intervention to ensure they don't go back into that overdose. But quite frankly, I mean, a person could refuse to do that. The likelihood that they'll be back in the overdose and 911 will be called again and they'll be reversing it would happen. We have not really had, we're in constant contact with our law enforcement officers, and that has not been something that's come up. There's definitely been something that's come up that they don't want to stay in the hospital. They don't want to be connected to treatment. There have been people there. Treatment readiness is a very real issue. People are in varying stages in terms of motivation for treatment, which is another reason why we want the recovery coaches in the emergency departments with that lived experience that can really engage in motivational interviewing and really talk to a person about the importance of seeking treatment.
So you said you put a recovery coach in the ERs. Is that physically or just like their phone number available?
So we are working on a project right now. There's roughly 11 emergency rooms in Oakland County. So it is a bit of a big feat, but we are working right now with connecting with two first, looking at the data and seeing, do we need recovery coaches on all three shifts? And no, it is physically embedded within an emergency room. We've done some real studies on what's called Project Assert, which is an evidence-based practice for recovery coaches in the emergency room setting. When I was at the Opioid Summit, I went specifically to a session regarding embedding recovery coaches in the emergency room so I could understand where individuals who have already done it within their emergency rooms, what were some of the challenges, but what were some of the successes. And overwhelmingly, once you get past working through the emergency room culture and staffing there, I've heard nothing but it being a benefit because there's people right there to help in that connection. And, you know, emergency rooms are very busy, physicians, nurses, very busy. They can give resources, but to have someone actually help and make that connection and kind of bridge that gap has been very successful. So our goal is to have presence in every emergency room.
Do you have any yet?
Not yet. You know, one of the biggest challenges that was reported and that I've read has been really helping emergency room physicians and chiefs of the ER in understanding the importance of this concept. It has happened in other counties, certainly the small counties that have, you know, one small emergency room in their, you know, in their entire area. We will do that. Crystal has been working diligently to set up meetings with the hospitals, but I would say that's probably going to be our largest hump, is just getting into there and explaining it. But we have a lot of research to be able to show the doctors, and I think once they really understand it, I really do believe that we will be able to be in the emergency rooms. So it has not started yet. It's a goal for fiscal year 18, and so we're working hard on that to hopefully have it in place by the end of this fiscal year. We'd like it in place tomorrow, but unfortunately, reality is a little bit different. Yes, by the end of the fiscal year.
Are there any more questions?
Yeah, I just had one question. First of all, I'm sorry for coming late. My apologies. You said you had increased recovery housing. Is there first of all, is it funded by the county?
So we are in the process of increasing recovery housing. We have 5 houses currently that are in Milford, and yes, we do fund those services. So if an individual is in need of safe and sober housing, they can contact our Access Center, and we will connect them to services. We have, in working with our recovery community, they have mentioned that we need more recovery housing, so we will be doing what's called a request for proposal and bidding out for even more services. So we did a request for proposal and had the responses that we had, but the houses we have are just not quite enough to meet the demand and need. So we are, will be in May, having another request for proposal to see if we can get some interested parties to bid for services. But I can connect you with the Milford recovery houses.
Any other questions? Seeing none, I'm going to ask somebody, oh, he's gone. Strategic plan. Kathleen, will you come up and talk about strategic plan for 19 through 20, fiscal year 19 through 21. Christina, did you have something you wanted to say?
Nope, that was it.
Oh, okay, here she comes. I looked and I did.
Good afternoon.
Yes, Mr. McDonald was gone, so, whoa, okay.
Thank you for the opportunity to speak to you this afternoon. As indicated, I really am looking for your input on our next 3-year strategic planning cycle. And our new three-year strategic plan would begin October 1st of this year for fiscal year 19, and it would run through fiscal year 2021. What you have in front of you now is our current strategic plan, and I wanted to provide that to you as a template of history and some of the things we've done in the past to get a sense of the landscape, the changing landscape, which we have to pay attention to because we have to know what's happening at the federal level, the state level, and the local level to consider where we may need to be in the next 3 years. There's a lot of change occurring. I don't need to tell many of you that. Certainly there's discussion at the federal level about the health care bills, expanded Medicaid is always a discussion, and certainly in Michigan, we have Healthy Michigan, but there have been some legislative changes around that recently in terms of work requirements. So what I do in leading the strategic plan is, again, pay very close attention to the federal level first and foremost. What I do is look at the strategic plan developed by the Substance Abuse and Mental Health Services Administration, or SAMHSA. Many of you have probably heard of that. It is funded by the federal government, and it really sets the pace for what happens across the country in mental health and substance use services. The last three-year strategic planning cycle, I discovered that SAMHSA had created their own strategic plan. So for us to follow what's happening at the federal level is extremely important, because as we take a look at that information and incorporate it into our local plan, we really set ourselves up for being leading edge and preparing ourselves for any grants or funding that may come to the state, and then turn around and say to us at the local level, gee, would you like to apply for this grant to provide services? So today I'm speaking not only about substance and mental health services, but also services to people with intellectual and developmental disabilities, because it is a broad-based strategic plan for all the people that we support in this county. It's also important, certainly at the state level, to pay attention to what was happening. Many of you have heard of Section 298. It was a piece of written piece into our state budget a couple of years ago that basically said the state thought it would be a good idea to move all public mental health funds to the private Medicaid health plans. There certainly was an advocacy input on that, which said we really support our public mental health system and we don't think that's a good idea. Consequently, some of you may have heard that there are 298 pilot projects across the state in 4 areas where, in 3 areas of pilot project where the money would go to the Medicaid health plans, and then they would fund the community mental health organization. So those pilots are in their early stages. They've not yet been launched, but that is part of our landscape, and we're watching that to see how that develops. If that is successful, it may prove to be information to the department, our funder, as well as the state legislature, that they would like to move the money to the Medicaid health plans. Nationally, that is a trend that is occurring, and we're watching how that works in other states. There's mixed messages thus far. In a couple of states, it really has created a backlash, and there are lawsuits because people are not receiving the services that they had in the past. So that sits front and center to the work that we do. Some of you may have participated or heard of the CARES Task Force. That was also a Michigan legislative initiative to take a look at mental health services in the state of Michigan, as well as substance use. What occurred at that CARES Task Force really was a focus on substance use services as well as criminal justice services. So there were a number of recommendations made from that task force. So certainly those recommendations, the recommendations from the 298 task force, are things that we will look at and include in our strategic plan. Outside of the funding with 298, one of the recommendations front and center was around person-centered planning or treatment planning, and making sure that people served were very involved in their treatment and that the outcomes that people expected did occur and that people are satisfied with services. So those are some of the things we look at in terms of the landscape of what's occurring. As Christina indicated earlier, the opioid epidemic, as it's called, is also something that is certainly occurring at the local level, but at the national level, there's been a great deal of attention, and many of you know there's also been a great deal of funding recently set aside for that. I think we last heard it was around $3.3 billion had been allocated for that, not only in terms of treatment, but in terms of law enforcement and across the board. We're happy that there's a real focus on treatment in that, and I would suspect that as we go forward with this 3-year strategic planning cycle, that we'll see a lot of that embedded in the work that we do. Actually, it's in our current annual plan that we have right now. Let me walk you through a little bit of this document and backtrack also a little bit in that not only is this a 3-year strategic planning cycle, but it sets the stage for our annual plan. So although we have a 3-year strategic plan, the first year of the 3-year strategic plan will be our annual plan for fiscal year 19. So what will occur this year is the development of a strategic plan. Our board will approve the strategic plan probably in July, and then there will be a turnaround in a couple of months of an annual plan based on the strategic plan, and that annual plan will be approved in September of this year for fiscal year 2019. So as I indicated on the first page, you'll see under the introduction some of the landscape that was looked at last time. We had Medicaid rebasing and general fund reductions. That Medicaid rebasing has ended. And however, we're finding that our funding has had an ebb and flow, with some people qualifying for Healthy Michigan who perhaps could have more appropriately qualified for Medicaid through a Medicaid application. So that variation in qualification, although the services people receive are the same, has created a funding shift, because one application takes us into a funding reimbursement of $200. The other takes us into a $25 reimbursement. So across the state, we're finding a Medicaid shortfall to provide the services to us. So that's something we pay attention to in terms of not only this issue, but any funding issue that occurs. So we'll continue to watch that funding. We'll watch Healthy Michigan and what occurs with that. Many of you know that we have a home and community-based waiver transition plan that needs to be, the department would like to see us complete by 2019, but technically we have about until 2022 to complete the home and community-based waiver transition plan, which really ensures that there's community participation and involvement of people, and that they're actively involved in their services and have choices in their lives. It right now applies mostly at this point in time to people with intellectual and developmental disabilities, but it will apply to all people that we support in the not too distant future. We take a look at all of this information. We do some data analytics. That also is very important. We have a lot of data at this organization and dashboards. I don't know if Christina and company here have had the opportunity to show any of the dashboards that you're using. I know a number of them are under development. It's taken a while to get the right kind of data that we want, but certainly to be able to call up reports on the shifting population that we serve. So we'll look at the ages of the people that we serve. We know there's aging in America that happens in the people we serve. So we'll look at that and really do some analytics around what services are likely to occur to people, and what will that mean in 3 years in terms of how we need to develop the provider network and how we need to fund the services that are needed for people. Next page, page 2, shows you our agency's mission, vision, and values statement. We are likely not to change that, but I always like to say when we're seeking input, if you find that there's a value that should be added, please let us know. Or sometimes even a word, even in our mission, might emphasize what it is we do in a much better fashion. So anything is on the table, or nothing's off the table, so to speak, in terms of feedback. So if you'll please take a look at mission, vision, and values, and if you have any input, please let us know. Those are the values that guide us. The next page has to do with our principles and practices, and we quite frankly have a growing number of bullet points in this area, and we also are resculpting some of the phrases in there. I know that recovery is a word that fits certainly in the realm of substance use, but it also fits for people with mental illness, and the feedback that we got was, gee, we see how that word fits in these statements more for people with mental health concerns, but we don't see ourselves if we are people with substance use concerns. So we want to add some language there to make it very clear to people who come to us for services that they are included in the strategic plan, in the work that we do. We also know from some of the feedback we got that we want to add zero suicide initiative to this. Chaka talked earlier about the suicide rate, or that the fact that there's a lot of suicides in the veterans community. It certainly is an issue all over and in Oakland County. And so we have started a zero suicide initiative this year, and we'll add that to our value statement. But there may be other things here that needed to be added, so I please ask that you take a look at that and offer some input. Strategic planning process is one where we do talk to a large group of people. I try to get around as much as I can. I've talked to probably every team in this organization. I've been at clubhouses, drop-in centers, and certainly I'm here today to get your input, and you have a network of people that you work with. So if you could be an ambassador for this work and take it back to where you work, or groups that you talk to, and talk about what are the needs of people, what works well in this organization, what needs to be improved, and then get us some feedback. We'd certainly appreciate that. The next page talks about the last 3-year strategic planning cycle's strategic priorities. There are 7 of them. A little unwieldy for some people, but we're very ambitious here, and we wanted to make sure we covered these areas. I might let you know that 3 years ago or so, the substance use team and the services that they provide were new to this organization, and so they were included in a goal and an objective area in this strategic plan, and there was a 3-year strategic plan related to substance use. The department had required that. I know because I watched Christina and team develop that and then implement it. So you're likely to see a heightened visibility of substance use prevention and treatment in this next 3-year strategic planning cycle, because we've had, 3.5 years now of working on integration of the services into this organization. And I have to tell you, I've personally and professionally learned a lot. And I think it's been a good fit, because we do a lot of co-occurring work now, where before a lot of it was pretty splintered for the people that we supported. So more to come certainly in the strategic plan and annual plan. I'm not going to go through the rest of this because it does cover the priority areas under each goals and objectives under each priority area, and my intent is not to go over the last year through 3-year strategic planning cycle, but to seek your input. And before I open that up for comments or questions, let me just also give you a few trends that we're seeing. And a lot of it really has to do with technology. Everybody knows the speed of technology, and it creates changes whether we like it or not. And many of us are now wearing Fitbits. Not me, but I know a lot of people who do. Fitbits, people have Google Home or Alexa in their homes. There's a lot of interactive kind of technology. There's new applications all the time. This organization sponsors My Strength, If you're not aware of it, you can go to our website and participate in that. It's very interactive, and it creates a plan for each individual based on the input that they provide. So we expect really an increase in the use of wearables to get input on how people are doing with their treatment, and healthcare is extremely important, so we're expecting that to provide a lot of feedback. Telehealth, telemedicine is very big. Some people think, oh boy, I have to be personally in front of somebody. We're finding now, for many people, that's uncomfortable. And telehealth and telemedicine is creating better interaction and better outcome for people. So you're going to see more and more of that as we go forward. Transportation, we're hearing more and more about Uber and Lyft as being solutions for people who don't have transportation to get to their appointments. As a matter of fact, we're reading that many of the larger healthcare organizations are already entering into healthcare contracts for that. So we'll be looking at that also. And I do know in talking to the substance use treatment providers not too long ago that there's at least one provider who is already accessing Uber to assist people. So those are some of the trending things we're already seeing and expect to use as consideration in the 3-year strategic planning development. So with that, I will stop and ask for comment or if there are any questions.
So on the principles and practices page, you indicated something about the word recovery with respect to mental health. And so I wanted to clarify that because I'm in recovery and I have mental health issues, so I could have a nice opinion on that. So I just
That would
wanted to
be great.
clarify what you're saying.
Yes, yes. I'm exactly saying that there has been feedback from some people in the substance use community that they'd like to see something that more delineates recovery related to substance use concerns.
From mental health concerns, is that what you mean?
Yes,
Okay,
yes.
so separate the two.
Kind of separate
Oh, okay,
them.
yeah,
A lot of the principles are the
totally
same,
separate, right.
certainly, but yes, they're
Yeah,
separate.
so that was
they
gonna
said,
be-
yes, this is nice, and many of us do have both, but we'd like to see more consideration given to substance use. So yes, if you have some language to offer, I'd be more than happy to.
They definitely are separate. And so if we had input, how would we contact you to provide it?
I think, is it okay if we offer it through you? You can certainly contact me directly, but it would be nice if it went through Christina, because then we'd kind of get a sense of a whole on what you're thinking. Everybody's individual, certainly, and sees it from where they sit, but it'd be nice to give input.
Thoughts? Did you have something to say?
No, I didn't, no.
Okay, I have a quick question. On your page 5, you mentioned criminal justice as one of the strategic priorities. Help me with that.
Covers everything from staff or liaisons that we have embedded in the court systems.
Jail.
Jails, yes, the MAT services. It includes work that's happening at Children's Village. So it covers the full range. And really, we know that a lot of that work overlaps with the work that the substance use team does on behalf of the people served. So there are no silos. We work across teams, across issues with each other in this organization.
County, I just received a bulletin that the main concern, we too do the same thing on a 5-year basis at the county in our budgeting, 3 years and a 2-year outlook. And the one thing that is stifling us is the Indigent Defense Fund, or Indigent Defense period. This isn't really truly an unfunded mandate, if in fact it goes through, in which it'll cost the county, because we have no facilities, about $19 million to build a building. Remember, we have to replicate everything we have in the prosecutor's office. In addition to that, it'll be about an $9 million, there's quibbling over $1 million at this point, cost to the county annually to provide this service. Now, along with that, will also go, obviously, requests from community mental health and from substance use to provide services or to testify or whatever at various, do you understand where I'm coming from, trials? So I hope you consider that as an add-on, maybe, because we don't know where it sits. I do know that the Michigan Association of Counties, and other statewide organizations are absolutely opposed, not to the idea that people shouldn't have a defense, but to the idea that this is an unfunded, huge mandate. And we simply in Oakland County do not have the funding, the monies for this, nor do our little itty-bitty counties where they're lucky to have any mental health or, so you know what I'm talking about, Kathleen, and the rest of the state, which is sad. They don't even have jails. And the other part of it is that in addition to all the defense bar and so on, we also have to provide individual rooms so that every client has a right to see his or her attorney privately in a private room. So that means updates to all the jails and all the courthouses. And that's not factored into it. So that's it's very costly without the state coming up with funding for it. And right now, there is none, so it's kind of a difficult thing. So I think you should take it into consideration as the county did it. They did their regular planning, and then they said, if, in case this goes through, we're going to have to really cut budgets here, there, and everywhere.
So is this a piece of legislation that has already been approved, or is it pending?
Well, the legislation has been approved. However, rather than a subcommittee or a committee was formed, and the committee does not consist of anyone, whoever has to deal with budgets. It's kind of like a pie in the sky. You know, if you grab a bunch of people from the outside, they're going to tell you, do everything, everything in the whole world. You know what I'm talking about. And you wish you could, but you can't do it because you just don't have the funding for it. Well, that's the committee that was set up. They're very well-meaning people. Okay, I get that part. I think we all get that part. But the reality of who's going to pay for it has not hit because, and so if their plan is adopted by the governor, that's it. Unless somebody who understands, revenue and gets that piece of the picture. Because we would like to, if the county help everybody, and I'm sure you would too, but sometimes it's not possible to do everything for everybody all the time, so, yeah.
If I may ask if you have that legislative
I was looking
title
for it
or
on my
number,
phone. Yeah.
I'd be happy
All right,
if you
yeah,
could
I
give
will
that
get
to
your-
us, and we'll
I'll-
track that.
Oh, the legislation?
Yes, or the
Okay, I was going
name of the
to, I was going to
subcommittee.
send you the letter that came from the county, that, yeah, you could do that, and then you can take,
Work.
yeah, it's already gone. I mean, there's already an effort to have an indigent defense department in every county. But, as I said, some of these counties don't have jails, and their courthouses are the size of, this room is a pretty big courthouse, so, yeah.
Thank you.
Any other questions? Okay, Kathleen, thank you very much.
Thank you so much.
Sorry, I couldn't find that. I tried to find it here. I didn't succeed.
I could make one last comment.
Yeah.
If, I always say to people, you probably think about these things as you're driving home or driving to work or wherever you get your aha moments.
But not 2 o'clock in the morning.
Well, sometimes that happens too. Thank you. So please know that we take input right up until this is approved by the board. So don't feel like, oh gee, I've missed my window of opportunity to provide input. Please know that up until the board approves, there's opportunity to effectuate change. And believe me, I have been tinkering with strategic plans and annual plans the day before it goes to the board. So please know.
What was the day then that you're planning?
It will be the board meeting. The strategic plan will be a July board meeting, which is usually the third week in July. And there will be a public forum relative to the draft plan the end of June. So there is plenty of time yet. Thank you.
Thank you. Sorry, I couldn't find that here to send to you, but we'll get it. Sherry Williams is going to talk about treatment.
Good afternoon. Individuals enrolled in medication-assisted treatment participated in focus groups sponsored by the Michigan Department of Health and Human Services. The participants gained insight and awareness about risk and harm reduction strategies related to injecting drug use, engagement in sexual activities, and community resources. OCHN, we have 3 medication-assisted treatment programs. We have Sacred Heart, which is located in Madison Heights. We have Biomedical Behavioral Health Care, which is located in Waterford, and Therapeutics in Wixom. I am so pleased to announce that we are in our 4th week of deployment with our Oakland Data Information Network, also known as ODIN. It is our behavioral health care electronic record for OCHN providers. The implementation date for substance use providers was April 2nd, and we sponsored trainings and webinars for staff to learn how to operate ODIN. And as I stated, I'm pleased to say that it has been somewhat seamless, much to our surprise. And our team and the IT team, we will continue to provide technical assistance to our providers to ensure that they understand the expectations. But it is our effort, one of our efforts in continuing to integrate services, mental health and substance use services. I'm also pleased to announce that we sponsored a Recovery Coach recognition event, and that was scheduled here on March 28th, and there were approximately 20 participants. Acupuncture services were provided, and speakers encouraged participants to engage in self-care practices because that's often so important for peer specialists and recovery coaches, in addition to providing information on trauma and women's services. And it was a well-attended event. We're also going to be sponsoring a CCAR training. And CCAR is a Connecticut Community Addiction Recovery Training. And it is a 40-hour skill-building certification process for individuals who are interested in becoming peer recovery coaches. And the training is March 30th through April 4th here at this location. And we have approximately 39 individuals, peer recovery coaches, who are providing services throughout our network, including the RISE Center. Are there any questions?
Christine, did you have a
Just a quick correction, it's actually April 30th through May 4th.
Thank you, Christina.
You're welcome. Well, I have to say, just a quick note, in addition to that, that's one of the rare times Sherry makes any kind of mistake. And I just want to give a lot of recognition to Sherry and Megan Phillips, our access supervisor, because they worked for the last year tirelessly on the deployment of ODIN and moving from one electronic system to the other, training all of our providers and writing all of the benefit packages, you name it. Our IT team was amazing as well. The utilization management team was very helpful as well, but a lot of transition occurred not just to an electronic system, but the way we authorize services to be more in line with how our organization as a whole operates. And I think Sherry minimized how much work that she did on this, and I do want to give some recognition to her at this point.
Thank you, Sherry. It's not easy. It's one of the worst jobs in the world.
It was.
It's been pretty intense.
Yeah, I did it 3 or 4 times in my business, so I don't like, it was awful. But when it's done, it's good.
It is, it is.
Yeah.
Thank you, Christina.
And if anyone ever has an idea to change it, you say, no, not in my lifetime.
I'm running for the border. I'll run for the
Either border, any place, yeah, I would too. Okay, Megan is sick, so Christina, you're going to pinch hit on access.
Sure. I just want to,
Or there questions, I'm sorry.
Quick question. Is there a fee for the recovery coaches to take that Okay, and what are their qualifications prior to the course?
Just that you are in recovery and that you're interested in providing support to individuals who are in treatment.
They have to have a certain amount of clean time?
We have parameters built into our contract regarding clean time, and our expectation is 2 years.
Thank you, Sherry. Any other questions? Okay, your turn, Christina, again.
Okay. Megan wanted to kind of give a more in-depth update about the sober support unit. If she were here, I'd also be saying, commending Megan, because the sober support unit is housed in our resource and crisis center right where access is. And so Megan really is working very, very closely with Common Ground on that, troubleshooting any issues, connecting people to services. If someone comes in the night before, the access staff go to the unit and screen them and get them to treatment. And so it has been amazing for the community, and also a lot of hard work, but really work that we are very willing to do and happy to do, because we want people to survive the epidemic and just to enter into recovery. It's our main goal. So we had a soft opening in August, and that just means we didn't really announce it to the community, because you know what? Anytime you open a new program, there are kinks. So we wanted to kind of just softly open it and see what we needed to work out, which was actually very helpful to do that, because, you know, you try to anticipate things and you don't anticipate everything. So we really formally opened in October. And we're well above the 256 now, because we just keep increasing as the community learns of the sober support unit. As I'm out in the community a lot, talking at different forums. Obviously, I'm talking about it a great deal, and so it just continues to increase. Some of the nice initial statistics, though, is that 98% of the individuals that came into the sober support unit followed through with the treatment recommendations that we gave and went to treatment right from the sober support unit. 73% of those individuals, just for some demographics, were male, 27% were female. That's very in line with the statistics we see when we look at our demographics at the end of each fiscal year. For males, this is somewhat interesting. The primary substance that an individual reported using was alcohol, and that followed closely by heroin or other opiates, meaning the prescription opiates. Now, for many years, the number one substance people sought treatment for in Oakland County was alcohol. But as the opiate crisis began, we started seeing this shift in data around 2008, 2009, and it just started to really climb. And first, it was prescription opiates. We took over as the number one reason why people sought services. And then together, it first started together. If you mixed heroin and prescription opiates, it was a higher percentage than alcohol. Then prescription opiates just overtook and became the number one reason people sought services. And then that graduated to heroin. As of last year, it was still heroin that was the number one reason people sought services. But I find it very interesting that individuals, their primary substance they identified with that have come into the sober support unit is alcohol. Again, it's still a high percentage of individuals with opiate use disorders. And then there's a sprinkling of cocaine and benzodiazepine use, which is an example of that is Xanax. So again, we're very happy. That's a lot of people that we connected to services, many of which came in on holidays, weekends, and after hours that we may not have ever seen if they had to wait until we were open during the week. A lot of times, I would say most of the time, time is of the essence. When someone is ready to seek treatment, you want to be there and connect them to treatment. And so for us, that is a real win, that individuals can come in at any time and we can connect them. Some of the future measures we're going to be able to look at, especially with the new system. The new system is very helpful. It has a lot more features, so we can really, really do a lot of data-driven decision-making and take a peek at things. And one of the things we really want to look at is not only are people going to treatment, but are they staying in treatment and then following through to the next level of care? So if we say someone comes in to the sober support unit and we immediately transfer them to withdrawal management and then residential treatment, first and foremost, did they stay for the whole stay, or did they leave against treatment or medical advice is the first thing we want to monitor, because that'll tell us where do we need to beef up services, where do we need to add recovery coaches, what can we do to help a person stay in treatment. But then the second very important thing is that residential care and withdrawal management, first of all, is not a treatment service, it's a medical service. It's to mitigate symptoms so someone can actually engage in the treatment process. And residential treatment, you look at it as your most acute care. You're really stabilizing an individual. What's so very important and what statistically it tells us is it's the wraparound services in the community for a person. So your individual, your group, your family therapy, your case management services, your recovery coach services, the acupuncture that you can receive, the yoga services that you can receive, and just overall wraparound supports. And so when people don't follow through with their outpatient aftercare, they tend to relapse. And so what we want to start looking at is, are they following the full continuum? Did this immediate connection to service help us and a person to really engage in services from the beginning with recovery coaches, which we are finding to be of the utmost importance to a person staying in treatment? And did they stay the whole time and enter into recovery? And so that's some of the things that we're going to be really looking at, because that can tell us where we need to increase supports if anyone is struggling. The other thing is, I just want to say again, this would not be possible without PA2, so we're very fortunate to have it. We're very careful with how we spend it, but at the same time, and that's so we can do unique services such as this. So the initial budget when we costed it out was about $589,000 a year. For this first year, it's projecting out to be about $532,000. So it's always good to project for anything that you can possibly consider. And then it's definitely okay to come in under. You don't want to go over budget. So that's our projected cost. We'll keep looking at it. It is so money worth spending. Again, in the midst of a crisis, you want to be able to have people access care immediately when they are ready. Any questions on the sober support unit?
Any questions? I just have one. Sure. And I don't know if you're able to do this, but let's just say somebody comes in for treatment tomorrow, and they get sober, and they get through it, and they go through this, and somewhere down the line, 3-4 years later, they have a relapse. It can happen. Okay, we all get it. So will you be able to track that person? Will that person be a new person in the system in 4 years? Or will you still have those records? Do you understand what I mean? So you can see.
That's a very, very good question. First of all, we will definitely have the records. And so while a person would be closed from our system, because you don't keep someone open when they've entered into recovery and they're doing well and they follow through with community resources, we'd be able to see.
Restore those records?
Yes. Okay. Those records are there for us to see. We funded their treatment before. So if someone relapses now, if it's unfortunately within 90 days, and a lot of times that happens when a person goes to residential care and doesn't follow through with their aftercare plan, because you need a lot of support and services when you're in early recovery. There's no question about it. So when someone relapses within 90 days, we are allowed to just simply really do a quick update. We don't have to put them through the full screening process and get them back into services. And then I want to remind people that, of course, anytime someone wants to go back to outpatient, they don't need to even be screened. They just go to one of our outpatient providers. They will reassess them for any current needs and open them up to be seen in our system. So we can see that. That does help. So we can ask some questions like, what worked for you the last time we put you through treatment? What was a struggle for you? Did you like this provider we sent you to? Would you like to go to another provider? Perhaps some issues have happened that another provider is a better provider for them to go to. maybe it's women's specialty, for example, and they didn't go through women's specialty services the first time. So yes, we can see that. We'll see that the case is closed, but we certainly will be able to see their history, yes.
I just did something to
You're
that.
fine.
Any other questions?
I think just one quick thing I want to add, because this has come up in questions, so I want to make sure to clarify, is that if someone has private insurance, it doesn't preclude them from entering the sober support unit. What will happen is they will work with that person and their insurance benefits to see what is offered and what they can connect them to there. And we are actually in discussions. Harbor Oaks Hospital has a substance use unit that is for commercial insurance. And they just reached out to us hearing about our sober support and let us know that they provide transportation and that if a person would like to seek services there, they'll run their benefits for them, determine if they're covered through by Harbor Oaks. If they're not, they even said they'd go a step further and reach out to their insurance company to do what's called a single case agreement, and that they will actually come and pick them up. So this truly is a community benefit. It's not just for individuals who require public assistance in terms of their funding for treatment. It really is open to the entire community.
Okay, any other questions? Well, Christina, you're up next.
Actually, Crystal, I think, is going to address
Crystal?
prevention.
Oh, Crystal, I'm sorry.
It was my fault.
Okay, Crystal?
Good afternoon. I'm going to be doing the prevention update for Kathleen today. So we're going to start with SINAR vendor education. Over the next about month and a half, an intense education effort of tobacco retailer occurs throughout the state. In Oakland County, staff and volunteers from local community coalitions call upon their retailers to offer education. This education includes information regarding the strictures of Michigan's Youth Tobacco Act, YTA, and offers tools to train employees in complying with the law. The goal of the activity is to have a majority, 80%, of tobacco retailers refuse to sell to minors in a federally mandated inspection later in the year. Last year's refusal rate in Oakland County was 92%, which is pretty good, I think. The next is life skills training for the prevention model. LST is a well-known research-based prevention program employed by 6 of OCHN's prevention providers. It has recently added an additional education module that addresses the non-medical use of prescription drugs and is designed for use in 6th to 9th grades. OCHN provides funding to purchase the additional module for prevention providers in light of the opioid epidemic. And last but not least, the National Prescription Drug Take-Back Day. This coming Saturday, April 28th, local community coalitions will partner with the Oakland County Sheriff's Office to offer residents additional and convenient locations to drop off expired and unused medications. They are disposed of in a safe and environmentally friendly way. The campaign's goal is to reduce access to prescription medication, especially for youth. And it's a really good program. I don't know if any of you had to use it, but I think it's really good. Go and look in your cabinets, whatever you may think. I've had to do before any kind of medication. It's been very helpful and beneficial.
Crystal, thank you. Are there some questions? I just want to say that even, you said any kind of medication, I want to stress that. You may have some old over-the-counter this and that, and it's expired and it's, you're not going to take it again. Throw it in there. I will tell you also that when they burn over at the sheriff's office, burn this stuff, it is ghastly. If you've ever been over there, don't go there on days because you can smell it from the incinerator. There are also local communities have drop boxes any time of the day. So if you go into any of your cities or most of the cities, they will have drop boxes. Or you can even go to your police department and give it to them, and they're happy to take care of it from there. You don't have to travel all the way out to the sheriff's, department. Any questions, more questions?
I was gonna say, I think that's a good point. One of the things Oakland has done that's very nice, I mean, everyone participates in the National Take Back Day across the nation, but the reality is we have 36 drug drop-off points in Oakland County. So almost every police department, you're pretty much guaranteed that you can go to your local department and drop off medications. It's just the medicine cabinet is not a safe place, especially for prescription narcotics, because you don't know who that's used in the bathroom could go into your medicine cabinet. So it's very, very important that when you have expired or you're not using medications to be able to get rid of them, and it's really quite easy.
And senior citizen complexes, congregant living and such, they also celebrate this day and go door to door and tell their residents. Many of them do, so it's good to know, for you to know that, and to remind our seniors that that's a good thing to do.
I want to say my Walgreens has a drug take-back box. I don't know if they all do, but mine does, so.
Yeah. Yeah. Thank you, Crystal. Okay, next, we have some old business. Christina?
Yes.
We have, first of all, before Christina goes there, I'd like a motion to approve the January minutes. Moved by Dr. Klotz and supported by, by Dennis. Okay, well, we do it at the end here. We could do it, any additions or corrections to those minutes? I don't know who took them. Somebody did, but,
Dawn takes them every time.
okay, Dawn, spell my name with an EY, okay? Shelley is an EY. That's my correction. Any other corrections or additions to the minutes? Seeing none, all those in favor, please say aye.
Aye.
Opposed, same sign, same, okay, motion carries. Our minutes are done or approved. Christina, would you like to go into old business?
So for old business, we still have some vacancies. The vacancies are specific. You know, there are rules that were made up and approved by this board and are in line with the law that outlined really who you should have on your board. And currently, right now, we have vacancies for someone that is in prevention. We have another religious affiliation vacancy, and we have another person in recovery vacancy. Those are the 3 vacancies we have right now to seek to be on this board. So if anyone knows anyone that would like to be on the board, they can either send an email to myself at nicholasc@oaklandchn.org. That's NICHOLAS, C as in cat, at oaklandchn.org. And I can walk you through, I will send you an application to request to be on the board. And certainly, if this board has anyone that they think, they can always send them to us, and we will send an application, and then a determination will be made if they fit the general makeup of what we are looking for in terms of a board member.
Okay, any questions on this? If you know anyone, give Christina a call if nothing else. Finally, Oversight Policy Board member issues and announcements. Does anyone have an issue they'd like to discuss or an announcement to make?
Something.
Okay, Kelly?
So last meeting, you talked about the gain assessment. And so I really got a bee in my bonnet over that, because I know what it's like to need mental health services and not want to make it hard. So I did some research on it, and so I don't know if maybe you guys would know the answer, if this is like a final decision by the Michigan Department of Health and Human Services, because I found reasons why they most likely made the decision, although I can't say for sure, but I also found evidence why they made the wrong decision. So I don't know if, it's final, you guys are done and through, you have to do this, or if it can be appealed, or...
At this point, we have been told, because we were one of the most vocal, but every single PIHP was very vocal in opposition of this. Providers were very vocal in opposition, and we have essentially been told that we have to do it. We tried many different avenues. I frankly am not quite sure, other than what they are saying, which is the fact that we have the 1115 waiver, and that's for Medicaid services, that has to be passed. One of the things they're attributing in that waiver is that with Healthy Michigan, well, let me back up. In Medicaid, there was a rule called the Imd Rule, which was the Institution for Mental Disease. Yes, that's a very old way of terming it, but we'll show you how old it is. That indicated that you couldn't have a facility that had more than 15 beds in it and use Medicaid services. So they created a waiver, per se, that didn't apply to Medicaid in terms of mental health services, and there was a lot involved in it. One of the reasons they're saying they need to get this passed is that with Healthy Michigan, they're worried about the Imd rule with regard to substance use disorder services. I don't know of any facility in the state of Michigan that is 15 beds or smaller. So certainly if the feds were to really push that right now, we would literally be flatlined in terms of access to services for people that need a higher level of care, such as residential. I'm not sure that's the entire reason. You know, I question it, but those are the answers that we are being given, and essentially told that this is a mandate. And again, we had several meetings. The last meeting I had, I was extremely vocal and ultimately said, so at this point, there's really nothing we can do. And they basically said no. And so they have pushed out the trainings. They say that it's going to be effective October 1st. One of the things we did push for and received approval is that it's only going to have to be done every 6 months. So it's less than what they thought before. And I certainly know that we will continue to give feedback, because it is long and cumbersome. It is the shorter version, but even the shorter version is extremely long. They think it won't take, this is just what's been reported to us, that it shouldn't take longer than a normal intake. I don't know that individuals agree with that, but the proof will be in when people start to assess and can give that feedback of whether it's that takes that long. We personally think that it is going to take longer, which is going to drive up costs, because anytime you keep a clinician in an intake longer, it's less people they can see. And so therefore we have to compensate for that. What we're having to tell people is that they can't use any of their other assessment tools, which wouldn't be fair for an individual, so for being mandated to do it. So their intakes are just considered null and void at this time. And that we've asked for providers to send back feedback on what they think it would cost to do an increase. So we've had to sign a data use agreement. It was the first of the signatures. And you know, we kind of said, do we really want to sign this yet? Is this, you know, over? And the PHPs got together, and it is, I mean, they're really, the ship, one of the terms used was the ship has sailed. We have no feedback.
PHP?
PIHP is who we are, Prepaid Inpatient Health Plan. And so we're the monitoring body and the holders of the funding of Medicaid and the block grant for substance use disorder services. And that's basically what the state of Michigan calls the 10 of us around the state that manage the public mental health, intellectual and developmental disability, and substance use disorder system.
We are very lucky, I might add, in Oakland County, being our own PIHP, because many of them have 10, 12, 20 counties, and you can't imagine the squabbling over 20 counties. You can't, yeah.
Wayne, Oakland, and Macomb are single county PIHPs, so which means that we manage both the general fund and the Medicaid. Other counties that have numerous counties under them also have numerous what are called community mental health service programs. We're both a community mental health service program and a PIHP. And so, you know, there's a lot of different dynamics in other counties, so it does have its own set of dynamics and things to work out as well.
Yeah, it's not really a corporation. The foundation that made up the test and hands it out does claim that the short version is 15 to 20 minutes, is what that's what they claim. They're long, like I have their literature is what, actually found, a review of the screening assessments, and they claim that it's the short version, let me see. This document is not. This document reviews like about 20 or 30 different types of instruments for assessing. It's Network of Alcohol and Other Drug Agencies. And it's kind of old, but still.
Kelly, could you share that with Sherry?
I can do that.
Okay, you know, you can make a copy if you wish, Sherry, I guess.
Yeah, I did
That
make
would be
copies.
helpful.
I did make copies.
great.
Everything that I have here, I have 10 copies of.
Perfect.
I can get, they allowed a download, so I do have a electronic version too. But it states that the regular gain initial is 60 to 120 minutes, and this is their evaluation, so I guess this isn't the gain company or whatever you call it. But then the quick is 15 to 20 minutes, and then what they have SS, short screen, is 5 minutes, is what they say.
So the 77-page short version is
Seriously.
likely to take a lot longer than 20
Yeah.
minutes. The state of Michigan is saying it should be about an hour and a half.
That must be this one then. That's,
It's the full one.
oh, is it? Okay, but they're calling it the short version?
Well, there's a 120-page version, and then there's a 77-page version, and then there's a screening. And they're mandating we do the 77-page version, but I can't see with the amount of questions, because we've seen it, how that could ever be asked of a person in 15 to 20 minutes. The only way that it could be that short is if someone answered no to almost all the answers, because it kind of works that when you say yes to something, then there's a whole new set of questions. So I think it's unrealistic to say 15 to 20 minutes. I wish that was true. Was this for us to pass out?
Yeah,
Okay,
pass those
perfect.
down. And the Network of Alcohol, this review, it's only partial because it was like,
lot of pages.
like many pages. So I just took out the relevant stuff because they evaluate every single one that's on here.
I'm going to go this way for Dennis.
I already gave him some.
Oh, you did?
Yeah.
Dennis already has his. And then I'll keep one, but I need to pass these to you. Oh, okay, gotcha.
Well, if you don't mind me saying, probably the 15 to 20 minute in the game, there's several different parts. And so the state is doing the one that's the most comprehensive, which is the 70-minute. And if you go, you can look on their website if you just want to go and look on Chestnut's website, and it breaks down which each component is for, so that you can see this screening is specifically for different areas. But the state is doing the gain one, the full assessment.
Right, and that's what I
Yeah.
saw, is that they're taking it for the wrong purpose. They're taking the one with the wrong purpose and using it for evaluation of people, where the one they're using is really for evaluation of your entire practices and mental health system, and it's usually funded by a government. You know, like you get the specific money. Obviously, you guys already know this.
Yeah, Kelly, I want to thank you for doing this. It's exactly what I was talking about. Somebody with great eye, but they've never worked in the field. They don't get it. And so consequently, eventually, we're going to have a turnaround and do something about this, because it is way too long. Someone is in need and hurting, and you're asking them, how old were you when you bounced the ball in the playground?
Right,
type
I'd
thing.
left. I'd have been gone.
Yeah, exactly.
So one of the
Exactly.
things, these are all the same things, you're right, that we shared.
Yeah.
And one of the things, because, I would have preferred to be able to work together and come up with a shorter version tool that, you'd have to make sure was reliable, et cetera. The biggest thing is that you have to have ASAM, the American Society of Addiction Medicine placement, patient placement criteria embedded within it. And what has been said as the gain to this day is one of the only assessments that has ASAM fully embedded. We've embedded ASAM into our screenings and assessments for many years. It's how people are determining level of care and needs. And we expect our providers, every time they do a reauthorization or an authorization, to utilize ASAM in making their requests and determinations. And we utilize ASAM when we are screening a person. The reality is there's a lot to asking, to finding out, and to helping a person, working with a person on what they want and need. So I can understand an initial appointment being longer. That happens when you go to any physician, things like that. But it just needs to have good merit to it. And I think it could be achieved in a less cumbersome way. Certainly, like, as I said, my opinion has been well known at the state of Michigan. At this point, this is where they're going with it. And I've seen situations before where something has been started and then ended when it didn't work out. So I'm going to try to be optimistic and hope that all of my concerns are wrong, and we have no issues with this. But then I'll be also hopeful that if there are many issues, that it's reconsidered. But I agree with you. We don't want to lose people in the process, and that was my biggest concern as well. So.
Okay, any other
I
questions?
just want to compliment
Doc?
Christina and Kelly too, because you really took a risk, so to say, by being straightforward and confronting the whole situation. And your objections probably were not popular, but nonetheless, you said them anyway. So I really, really compliment you.
Thank you. And I had a lot of support from upper administration in terms of being, always respectful but very vocal in our concerns. The people we serve really are at the very forefront of this organization. Coming here or being here now for 3.5 years, it really is embedded into the daily discussions, really, of anything that we talk about here at OCHN. It's the number one thing. How can we better impact people's lives? What would be good for the people we serve? And if something isn't, that we are advocating and vocal about it. I have never worked for an organization that has the people that they serve more at the forefront than anything. And it really is, you can see it here on a daily basis.
Okay, any other questions? Kelly, I want to thank you again. I agree with you. I wish we could do something about it, but maybe we can. You never know. Okay?
This helps.
Yeah. Okay, any other questions, suggestions? Okay, we will see you, if not before, on July 25th. Does that sound right?
It does, but I would have to look at the agenda to make sure
Okay.
that it is correct. July 25th.
Okay, we'll
Yep.
see you July 25th, if not before. And thank you all for the work that you are doing on our behalf.
You.
Morning, everybody. I think we've arrived.
So.